essentially, when you have a patient who has developed these fluctuations, I think the use of enzyme inhibitors would be quite desirable, simply because we know that if you can block the catechol-o-methyl transferase enzyme that is responsible of degradation of levodopa in the liver, you can extend levodopa bioavailability by about 20–25%, which is a considerable number, and in many patients is already sufficient to provide more stability, even if they are only on 3, maximum 4 doses a day. Equally, if you use other enzyme inhibitors, particularly MAO-B, for instance, you can provide an additional benefit by extending dopamine availability in the brain. So really, I think particularly the young generations of neurologists and doctors should try to think a bit outside the box and think that it is not just managing Parkinson about increasing the number of tablets of levodopa until people take one every 2 or 3 hours, which makes the condition of the patient not necessarily better, but certainly has a negative impact on the quality of life, because you have to remember every 2 hours to take a tablet. Rather, keeping the treatment schedule simple may actually provide a clinical benefit and at the same time increase adherence and keep the quality of life of the people with Parkinson a lot better for a longer period.